And welcome to Deuk Spine Institute. We are going to be performing the Deuk laser disc repair on a patient with 3 discs that are damaged. One of them is on both sides, and he waited 2 years to come here, saving up his money so he can have the surgery done.
Try to stay still, sir.
See if we can make him comfortable. So we're going to be performing a left L5-S1 along with a bilateral L4-5 and a right L3-4 disc repair, Deuk laser disc repair, procedure that was pioneered here at Deuk Spine Institute. 18 years ago. Not the same facility, but the same surgeon and technique. Okay, there's 5-1. We're heading towards shot. How long has he had back pain for? 2 years. Motorcycle accident. All right. So the first thing I have to do is get down to the disc. Shot. And 5-1 is the hardest to do. I may have to adjust my starting point. Let's get an AP. I could start a little higher up. Shot. Just do a quick shot there, Jordan. Alright, so I'm more medial, but look at all the arthritis of that joint. That makes the joint enlarge. It's going to make the bone bigger than we want it to be. Alright, shot. Big bones are hard to get around. More challenging. Shot. Shot. When I say shot, I'm asking for an X-ray picture, not a shot of alcohol. Shot. Shot. Let's get an AP. Shot. All right, lateral. So his chief complaint is back pain. And our first step is to place these needles into the herniations. And his spine is very anterior. Shot. I just saw Dr. Patel, AP, who is going to be performing a kyphoplasty next on him. This patient actually has a fracture. All right, so my S1, L5-S1 needle, I don't like the position. It's being forced laterally by that bone spur there. I'm not happy about that. I'm going to have to try a different trajectory. Shot. The way the surgery works is we get to where we need to go using the needle. Yeah, interesting. Well, it's quite possible that that 4-5-1 facet has fused itself together, and there's no movement there now. I'm having a real hard time getting past it. It's enlarged, full of arthritis. I can feel it with the needle. Yeah, I'm not making any progress with it. Meantime, shot. At 4-5, we're making excellent progress. I can feel the herniation. Let's see an AP. Knife. Shot. Yeah, medial again. Let's go back to a lateral view. The 4-5 looks good. I'm going to make an incision at 4-5 on the right. We're doing 4-5 and 3-4, correct? On the right? Everyone agree? Shot. So let's get to 3-4. Shot. Shot. That looks really good trajectory-wise. Shot. Let's get an AP view. Spine is very anterior. Incredible how far forward it is. AP view looks good. Lateral. Very nice. Shot. All right. We've still got to figure out what we're doing at 5-1 because I'm having a real, are you okay? I'm having a, thank you. I'm having a real hard time getting to the 5-1 level with the facet pushing me away. Shot. I'm not ready to quit, but at some point, if I can't get there, I can't get there. What I've found on patients who have these abnormalities of their facets where they're unable to get down to the disc, a lot of times the facet arthritis will actually fuse the segment together, and there's no movement there. And it's very, very, very lateral. Shot. Once again, not happy about that at all. Shot. You put pressure there. Give me one more opportunity here. I'm going to try a little bit more lateral. There's not much more I can do. I'm almost as lateral as I can go. Keep hitting bone. Not supposed to be bone here, by the way, for those of you who don't know. The problem is the arthritis has gotten so bad in this facet joint that it's made the facet joint much bigger than it should be. And that enlarged facet joint is what's pushing my needle, because a needle is a needle. It can't go through bone, it has to go around the bone. So we're trying to go around. Alright, that's as close as I've gotten so far. Let's see if that's good enough. So we've got a right 3-4, right 4-5, left 4-5, left 5-1. Everyone agrees, right? Yeah, look how far away we are. We are too far away. I'm going to try a little more, but you see, show them the bone spurs and everything that's pushing us away. You can see it. And it's more, yeah. Actually outline it, go by the needle. You see that hard bone there? Yes. Yes, it shouldn't be there. All right, so we're too lateral. Let's try I mean, too lateral with the tip, which I've gone lateral to go medial to get around the bone spur, but it's not working. Let's try lateral view. Yeah, see there, we're right on the disc, but in reality, we're far away. So you can't just rely on, you know, unidimensional information. I'm still going to try. Shot? Yeah, look at that. That's way too lateral. Give me an AP. So his anatomy is blocking me from getting in. Yeah, we're not even in the disc. We're still too far lateral. There's no way to get to 5-1. Which is probably going to be okay since it's the least of his disc that's affected. So I just cannot do. Failed to access left L5-S1 disc despite multiple attempts due to anatomical constraints. So his body is just not letting me get there. All right, next. And by the way, any questions you have, feel free to ask them. So we're doing a left 4-5.
Okay, my friend.
Everyone agrees?
You're doing great.
Lay still. Let's put some more local.
Okay, relax.
Uh-huh. Yeah, I understand. We did put some, but, you know, it's fine. Put a little bit more. Shot? All right, so we're gonna... 4-5 is bilateral. That's what I'm aiming for, is the 4-5. Yeah, the 4-5 is usually not as difficult to get into. 5-1 is always challenging. Shot? Yeah, we got a right 3-4. Again, I'm hitting bone spurs. Shot? But I think we can get there. I'm going to just move my entry point more lateral. Shot? The right side is much easier in him. Probably because, that's it right there? That's it, probably because of the bone spurs, but also because maybe there's some twisting of the spine that's making the right side move more posteriorly. I always feel this part of the surgery is the hardest. Shot? Just getting to the disc. I think he's going to do fine when we're done, but I've got to get to that 4-5. Remember, we're going through a hole that's already on the side of the spine. Shot? And he has fairly advanced arthritis. I'm trying to get around this facet. Same problem as 5-1. Shot? I think you're off on orbit a little bit. I think you're about a degree or two. Shot? I think that's worse, don't you? You think that's worse? I think that's better. I may have to start more lateral though. I can still go a little bit more lateral safely. And that's what I'm going to do. Shot? 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 Too high. Shot? 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 Feel the bone spurs. Just a little bit lower than where I want to be. I'm going to back it up and reposition it. Shot? better. Let's do, oh yeah, shot. I feel a herniation. Let's do an AP. Definitely challenging me. Yeah, I think we're good. Yeah, I think we're good. You can see the bottom level. Look at how much more bone spurring and hypertrophy there is down there. It's crazy. Circle it for us, Jordan, on the AP. Henry, can you see this?
Yes, we can.
Not that, not that. Look at the lips coming out. Go down, Jordan. Go down. No, no, no. At 5-1. Yes. Yes, circle those lips going out. There you go. No. Yeah. It's above it. Yeah, that whole thing right there. Yes. So that's what's kept us at 5-1. At 4-5, it's not as bad shot, but it's still not normal. All right. I'm in, which is good. We're going to get this done. At 5-1. Okay. We're going to be doing what's called a discogram. We're going to verify his pain. We need him awake. How is he doing? How long has he had pain? 2 years, you said? I think it's been longer than that. I know he's had an accident. He also has a fracture, remember, T12. You awake? All right. We also have a piriformis, correct? Let's look at the consent form. Is it right or left? I think it's right, but let's just make sure. Yes?
Yes, right. How are you doing? You okay?
So we're going to release his piriformis muscle, which has been bothering him. The piriformis muscle runs here in the buttock, and his is torn. He has piriformis syndrome, which is a torn muscle that just hurts and hurts, causes tightness and spasming. Sure. All right.
How are you doing? You okay?
Let's get his piriformis done then. Are you able to go AP? Num num. Shot. Go ahead, take a shot. Take that. Shot. Shot. What do you think? Knife? You happy with the rotation?
You want any more, doctor?
I'm sorry?
Okay, my friend. Okay.
Is he waking up?
Yeah, yeah.
Lay still.
How you doing? Can you open your eyes for me? Good. We're going to ask you some questions, okay?
Saved by the bell.
Go ahead.
All right. Are you having any pain?
You having any pain in your back right now? Any pain?
Shot. How bad is that on a scale of 1 to 10?
Give us a number. What number did you say?
How high? You can see the tear. Shot. All right. Let's put him back to sleep. So we didn't get a good response from him, but we know this is where his pain is. He started wiggling around. I need a knife. You know what's next, right? Shot. All right. Henry, why don't you play the video showing why do discs cause pain? Lights down. All right, welcome back. You can see from our video how a herniated disc will cause severe back pain in patients. The reason is inflammation. And what happens, you get a tear in the wall of the disc, the back wall. It's called the annulus. And when that annulus tears, the jelly from the center will come out in pieces, and we call those pieces herniations. Now, it doesn't have to come out of the disc. It can actually get embedded in the wall. We call that an interposed herniation, interposed. And that's what causes the pain. And it does it by creating inflammation in the wall of your disc, which is a very pain-sensitive structure, as we just witnessed, right? As we're putting the dilator in, the patient is having some discomfort. We see that all the time because that is a very pain-sensitive structure, the posterior wall. A lot of doctors think the disc itself cannot cause pain. They're wrong. It can. It's very common. It's actually the most common cause of chronic back pain and chronic neck pain, accounting for 85% of all chronic back pain. 85% of the time, the disc is the primary source, the main cause for lower back pain. 90% in the neck. All right, I know we have some questions as we clean up this first disc. This patient, by the way, came all the way from India, from Delhi, New Delhi, and with his wife. And he's been watching our surgeries for 2 years. He's been saving up his money, and finally he's here. And we're so happy to see him here getting fixed. Robert? You have some questions, Henry?
Yes, we do. This first one coming from JJ on YouTube,
Hello, JJ.
asking a pseudodisc. This one is different. I've been at back pain for 2 years. Back pain for 2 years was stated, I believe. I'm curious if there could have been arthritis before the motor vehicle accident.
Oh, yeah, I'm okay. So first of all, thank you for asking a question. I'm a little bit confused. I didn't know if you're talking about this patient or yourself.
Yeah, that's why I got a little confused with as well.
So I will assume you're talking about this patient. Is that a pseudodisc down there? The answer is no. It's 100% not a pseudodisc. He has a real disc at 5-1. And the reason I know that is because the facet joint is all arthritic. So a pseudodisc is when you have a disc that you see on MRI or X-ray, however, there's no real movement at the disc because the back part is actually auto-fused. You're born that way. There's no movement at the disc. Therefore, the disc itself, as an adult, it looks perfectly normal. And meanwhile, all your other discs don't look normal. And the reason, because there's no movement. So it's not actually bearing any weight. It's not actually getting loaded. It's not wearing down in your lifetime. You can't possibly injure it because it's not a real joint. It just looks like a real joint on diagnostic imaging. That's a pseudodisc. This patient has a real joint at 5-1, and it's worn down. Unfortunately, the wear was more eccentric on his left, so he's had more loading on his left, on that left facet. And that left 5-1 facet has gotten bigger over time. Wolff's Law, it's called Wolff, W-O-L-F. Wolff's Law is that bone will react. Bone is a living tissue. And a lot of people don't understand that. They take it for granted. They think bone is just, you're born with it, that's it. But bone changes over time. And it's dynamic. It's always being remodeled. And if you have stress on a bone, it's going to get thicker, stronger. We call it sclerotic, where it develops more cortical bone and less diploic bone, if there is diploic bone there. So this patient has put a lot of stress on that joint, the facet joint, and it's responded by getting thicker and bigger. And that's why I can't get into the 5-1 disc, because that joint is so enlarged. But it's not just the fact it's enlarged, it's enlarged in a way that it's protruding and out to the side right where my needle needs to go to get in. Now remember, I have a 1 millimeter window that I can get through, 1 millimeter. and that bone was covering that millimeter window completely and purposefully. So I tried every different angle, every other possibility, but to no avail. I was unsuccessful. And that does happen. We see it happen. Probably happens 1 every 50 patients that I treat where I can't get one of the discs. But the good news is every single time that that's happened, the patients always come out of here and their pain is gone. So I believe that that disc that I was unable to access is not moving enough because that facet joint is so arthritic, it's holding it locked in position. So it's not moving. And then therefore it's not creating much pain for the patient. So there's functionally no pain. Is that what I expect for this patient? Yes. We'll know tomorrow. He'll know tomorrow when I interview him and see how he's doing. But the only, if the disc itself at 5-1 is painful, there's only one option, and that is to fuse it at this point with screws and rods. And I honestly don't think that's going to be the case, but you know, it's a little too early to say. All right, next question.
Next question and comment both come from Robin on YouTube. Comment being, I have watched multiple videos with Dr. Deuk. His personality and skill set are calming and funny. All his patients are very lucky. Praying this will be me in the new future. I am ready.
Well, thank you, Robin. I appreciate it. Yeah, you know, the nice thing is when I'm in the operating room, generally I have time to be myself. When I'm outside the operating room, I'm so busy running around doing stuff that I have to be very short. But thank you. I appreciate it. It means a lot to me, and I'm glad you're here, and I'm glad you're learning, and I really do hope I can fix you someday. Just like I hope I can fix everybody someday.
And the question from Robin asking, I am just joining, how long did it take for his body to become filled with arthritis?
Great question, Robin. Generally, it takes years, many years, okay? And I use the term loosely, arthritis, because that's what most of the viewers understand. But, you know, arthritis just means inflammation of a joint, right? That's really what it means. So joints can be inflamed even in a child. A child that has a knee injury has arthritis in the knee. But we always think of arthritis as being this degenerative process that involves structural changes synonymous with advanced disease of a joint. So the truth is arthritis just means inflammation of a joint. In this case, is facet joints were the problem. But the real issue is not the inflammation of the 5-1 facet. It was the structural changes of the joint where it enlarged. And we call that facet joint arthropathy. Arthropathy and hypertrophy. Arthropathy is when the joint itself collapses and you get these sclerotic changes in the diploic bone, converting it to harder cancellous bone. You get shape changes of the joint and the surrounding bone, the facet, and they get enlarged, and they start to like have these like projections of bone into the soft tissues around them, and things get calcified and thickened, and it becomes very stiff. So it was really the structural changes, not the arthritis, and those structural changes come about because of arthritis. So it's the inflammatory condition in the joint and the synovium and the surrounding soft tissues that caused the structural changes, which then made it impossible for me to go in there and fix that 5-1 because I couldn't get past the facet. I couldn't get into the foramen, at least not safely. Now, unfortunately, there are doctors that would have kept going, and the patient will wake up with a problem, a serious complication. And but I know that would happen, so I didn't do that. I don't want my patient to have a complication. Other doctors either don't recognize the fact they're going to give the patient a complication because they don't understand the anatomy well enough, and they give their patient a complication, like a vascular injury or a neurological injury. Me, I've never done that because I know the anatomy very well, and I know where I cannot go. Okay, so I know we make these surgeries look easy, but the reality is they're very difficult surgeries to do. And there's a lot of potential for bad things to happen. For example, this fiber right there that you're looking at is 1 millimeter wide. And the tube internal diameter is 5.5 millimeters. So even though it looks like a really big space, it's actually a very tiny, tiny area we're working on. And a lot of people think that this surgery does big changes structurally on their MRI, but it doesn't. Your disc is going to look the same basically when I'm done, but it won't feel the same. That's the key. The key is that it may look similar, but it's not going to feel the same. It's going to feel great. And the way we make it feel great is by getting rid of the source of inflammation in the wall of the disc, in the tear, which is exactly what I'm doing right now. This is the annular debridement. It's being done with the laser. I'm removing this stuck herniation. I'm removing the inflammatory tissue. And by doing that, it gets rid of the pain. It works every single time. It's never not worked. Never had a case where it did not get rid of the disc pain. Now, people have other causes of back pain besides their disc. And obviously, if I'm working on this disc right now and they have pain from their piriformis muscle, it will not go away with this surgery, with this particular technique right here. I've got to actually operate on the piriformis muscle. It turns out this patient does have piriformis syndrome in addition to his bad disc pain. So we're going to fix both today. We're going to do the piriformis when I'm done here. He also has a fracture at T12, which Dr. Patel is going to come and do a kyphoplasty. All right, any other questions?
Yes, we have a question coming from Lanu on YouTube
Brian? Sure.
asking, I wonder if this super advanced surgery is performed on a UFO. The alien technology is incredible.
Thank you. Thank you very much. I think that's a compliment. At least I'll take it that way. I appreciate it. We're not on a UFO, though sometimes I feel like I've been abducted. We are right here in Florida. And I know some people from Florida act like they've been abducted, right? But we're still here, terrestrial. And we're at the Deuk Spine Institute. You can come visit us. We're easy to get to. We're just outside of Orlando. This patient flew to Orlando, and he's actually going to be heading home soon, back to India, I think. All right, we are done with one disc. I'm just going to take one more poke at this thing, and this is the left L4-5. I'm going to see if there's any more pieces of herniation I can get out, but you can see this is not a normal looking disc. So even when we're done with our surgery, the disc is still looking weird. It's still looking bad, okay? But it's not going to feel bad. That's the key. We don't want it to feel bad. I'm pretty happy with that. Yep, I'm happy with that. There's his nerve on the left there, that white thing. And the disc looks good. There's a tiny hole there. His body will heal that on its own. There's nothing I need to do or can do to help that. I mean, I just did it, basically. Cleaning it out. All right, questions?
Yes, this next one is either a comment and or seeking advice from, forgive me if I can't pronounce the name, but we're going to go with Siv on YouTube.
Siv, nice to meet you.
Saying, hi, I am from Cape Town, South Africa. I have arthritis in my facet joints and I've done a lumbar rhizotomy, but I am still in pain even now.
Yeah. Really? So Siv, the reason you're having pain is there's a couple of possibilities, and nobody in the world can tell you the right answer except for a doctor who's able to make the right diagnosis. And just talking to you right now, I can't do that, but I can do that if I can do a Zoom call with you and possibly a test or two. Long story short, facet joint pain is on the side of the spine. So if you were to take a line and draw a line down the middle of the spine like we did on this patient, you can see here, if you go just 2 finger breadths to the side, that's where your facet is, 2 finger breadths to the side. So if you have tenderness and pain, 2 finger breadths to the side, it's your facet joints, all right? If it's down by your butt crack, it's your SI joints. So that's kind of what I use as my determiner. And then if you're not sure 100%, facets are tender, so when you actually push, the patient will feel pain and tenderness back there. And so the first question is your pain from your facets? And if the answer is yes, then the reason you're still in pain is because the radiofrequency ablation you had done never cures that pain, ever. It's not curable with the RFA. It's just treatable. And these doctors will do those treatments, and the patients will feel better for a little while, usually a few weeks or months, and then the patient comes back and gets another one done, and they keep getting them done the rest of their life. Well, we do the same thing here at Deuk Spine with Dr. Patel and these RFAs. And I said one day to him, why is it not permanent? And he just said it just isn't. And he's pretty smart. But in concept, in theory, it makes sense. You want to kill the pain nerve. Well, then why can't you kill it? So I started to analyze it, and I realized the reason we can't kill it is what they're doing will never kill the pain nerve. It's not powerful enough, and it's not done properly. Like, as a neurosurgeon, we know how to destroy nerves, right? So I changed what's done and developed a technique that actually does destroy the pain nerve permanently, and it's called the Deuk plasma rhizotomy. You're in South Africa, so you guys have a very different system over there in terms of information protection, but in the United States, we can protect our discoveries and inventions through what's called the patent process, where we asked the government of the United States to protect our intellectual property. Well, our government agreed that my idea was novel and that it should be protected, so I got a patent. And, fact of the matter is, that's the fact you get a patent says this is so new and so different that we recognize it as being novel, which means other people aren't doing it. So to answer your question, the reason you have facet pain is that it hasn't been treated properly. You need the Deuk plasma rhizotomy to get rid of it. We can do that for you. The other option is that, as I said before, what? Yeah, please do. The other option is that your pain's not coming from your facets. It's coming from your SI joint, your piriformis, your disc. And the disc is the most likely cause of back pain. It's the #1 cause of back pain in the world. It doesn't matter what country you're from, a disc injury is the most common. And if I take 100 people with really bad back pain, and they've had it for more than 2 months, then the disc is the reason for that 85% of the time. Think about that number, 85. That's a huge number. That's like 90%, right? You got to make sure my pedal is here. Nikki, don't make me have to tell you again. So if you had a 90% chance of anything in life, that's a really good odds. Okay? I mean, in medicine, there's almost nothing that's 90% chance. But when it comes to pain in your back, 90% of the time it is the disc that's causing it, if it's chronic pain. Now, this patient has more than one cause, and his pain is in more than one place. He has pain up at T12, where he has a fracture that never healed, and I don't even remember if he knew he had a fracture. We diagnosed it for him but you can clearly see it's full of edema, which is inflammation, meaning that it's still hurting him. So we told him he needs a kyphoplasty done, which is where we go and put cement into the bone, and we do it with a needle. It's a very commonly done procedure. And I told him he can get it done at home where he lives, or he can get it done here. He chose to have it done here today. So we're going to do that later. Dr. Patel will do it. So to answer your question, I hope your pain is your facets, because that's pretty easy to fix. But you need the right treatment. And the right treatment is either a fusion. A fusion will stop facet pain, or the Deuk plasma rhizotomy. A fusion can also make your facet pain worse if you're not fusing the right areas. If you fuse next to the facet pain, it's going to make your facet pain a lot worse. All right, next question.
At this moment, no current questions.
Excellent. Let's show our video on how the Deuk laser disc repair works. As a matter of fact, why don't you show the audience how the Deuk plasma rhizotomy works?
Copy that.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Okay, great. So you just saw 2 videos. They're our newest videos that we just created. They're animations. They show you 2 things. One is how disc pain is dealt with here at Deuk Spine Institute, which is the Deuk laser disc repair. And the second video showed you, or I should say the first video showed you how facet pain was dealt with the Deuk plasma rhizotomy. The second video was the disc. And you can see they're 2 totally different problems. One is pain caused by the disc. The other is pain caused by the facet. They have in common certain things. Number 1, the pain is due to inflammation, whether it's disc pain or facet pain. So that means 95% of chronic back pain is due to inflammation from the disc or facet. It actually turns out 100% of back pain is due to inflammation. But the question is, where is the source of inflammation? With disc pain, the source is the tear in the back of the disc. With facet pain, the source of inflammation is the facet joint capsule and the facet joint itself, the bone. So it's primarily the capsule. So whether you have inflammation of your facet capsule causing facet pain, which right now the biggest common treatment is RFA, which doesn't fix the problem, or you have disc inflammation causing disc pain, there is a solution to either of these that's permanent. You just have to go to the right doctor to get it done. And the Deuk Spine Institute here in Florida, we're leading the world in these advanced treatments that other doctors don't even know about and don't know how to perform or do because they're so novel. Okay, but they're highly effective and very safe. This is the herniation right here, by the way. This material I'm zapping right now with the laser is the herniation, and it's stuck within the tear in the back of the disc. Now this tear is a result of trauma. And when I look at this herniation and these pieces I'm zapping away, I think this thing is, you know, several years old, right? It's probably even older than 2 years. But what probably happened was there may have been an older injury, longer than 2 years, that started the disc process where it was first injured, but then maybe things got stabilized and he was doing okay and got into another accident 2 years ago with a motorcycle, I think. And that made it worse. So I see stuff in here that's 2 years old, and I see things in here that are more than 2 years old. I don't see too much really recent herniation, like in the last 6 months. Most of what I'm seeing is like a year old, 2 years old, or older. I guess what I'm trying to say is we have different ages of disc material here. Disc herniation, different ages. There's a nice piece. So what I'm doing, for those of you wondering, is we are inside the tear and we're pulling out and removing the herniation, the pieces of the nucleus that are stuck in the tear. And the reason why they're stuck here is because once they got into the tear, his body's system, inflammatory system, said, hey, you're not supposed to be here. Let's get rid of this. Let's repair this. Let's first remove it and then repair it. The problem is it never got out of the removal phase. It got stuck in remove, this herniation, because your inflammatory system is not capable of it. It's like creating a computer program to do something it's not possible to do. And it has to keep doing it until it's done doing it, and it never gets done. We call it an endless loop. At least that's what we used to call it years ago, right? And your computer would freeze, and it would just sit there, and the processor was going, but it never finished the task because the task was impossible to finish. That's what's happening right here in all these patients with a herniated disc. They have a problem that his body is trying to fix, but it just is not possible. It will never fix it. So his inflammatory system is stuck in this endless loop of attacking, and that causes all that pain in the back and in the leg, and never stops because the job is never done. The cleanup is never done. Just creates scar tissue. Any more questions?
Yes, we have a couple more questions. This next one coming from Lanu, once more on YouTube, asking, this patient has a lot of problems. Is it possible his work or job has caused these problems?
Yes. Sometimes the job does cause these problems through repetitive stress or from an accident. And in the United States, we have a system for dealing with that. It's called the Workman's Comp Insurance System, but it's horrible because they're always trying to get out of paying for things. They don't want to pay. So will actually hire these doctors that are totally untrustworthy, that will do anything, say anything for money, and they will say that the patient doesn't have a problem, or that the patient's problem was pre-existing, the work injury. So they basically lie, and they get rewarded heavily for that. They get paid about 10 times as much as a doctor normally gets for seeing a patient.
He said he had 2 motorcycle accidents.
2 motorcycle accidents, okay. I didn't know there were 2. I'm not saying he didn't have 2, I just didn't know there was a second one. So that makes sense.
20 years apart.
20 years apart, all right, so there you go. So the original accident 20 years ago, that's why I'm seeing different age of the herniation, you know. Almost done. I've got a little bit more here I'm going to clean up, and then we'll be done with this one. Then I'm going to move on to 3-4. Great questions, by the way, and I love the comments and the audience participation. You guys are awesome. So let's see what we can see. Guys see that bit of herniation there? And
Yes, we do.
people ask me a lot, how do you know when you're done? Well, there's a piece of the annulus, by the way. You see the fiber right there? And you see how the herniation's coming out from it?
Yes, we do.
Yeah. So, you said there is a question or no question?
Yes, we have a couple more questions. These next 2 are coming from JJ, once more on YouTube.
Sure, I'll take JJ's question.
Asking, first question, I've gotten as far as being diagnosed by a physiatrist at a pain clinic of a quote facet joint misalignment and quote piriformis syndrome. I take that means disc injury is probable.
Yeah, so first of all, thank you for sharing. I don't trust any doctor's diagnosis except for mine. Doctors misdiagnose the source of pain in patients all the time. Is it okay? Luis? I think it's fine. I just pulled it prematurely. So my advice to you is to have me do your diagnosis. Okay? And that requires that you do our MRI review, which means submit your MRI form, submit your images, submit your report. 3 things. And schedule a Zoom call with my team. That's the best way to get a diagnosis. We found that my ability to make a diagnosis is about 95% accurate with Zoom and an MRI that's current and an exam on Zoom. So if I have your MRI form filled out, I have your report, and I have your MRI to look at, and a Zoom call, I can 95% accuracy diagnose the source of your back pain. That's about 90% better than most doctors, who are right 5% of the time. I say that because it's absolutely true. Absolutely true. Been doing this for a long time, and I have seen so many misdiagnosed patients that get treatments that never going to work, and the treatments are painful, expensive, and if anything, short-lived. All right, just about done. We got one more disc and then the piriformis and the kyphoplasty, which we're not going to broadcast that.
We have another question
Yep.
coming from JJ once more on YouTube,
Sure.
asking, should I be avoiding all stress to the lower back and become even more sedentary?
No. Sedentary is bad. You want to get fixed, JJ, and get back to a normal life. Again, my advice is get it fixed fixing it's either Deuk laser disc repair or Deuk plasma rhizotomy or piriformis release if it's a piriformis problem. I would never recommend to a patient to restrict their life on a permanent basis, and temporary restrictions are not going to fix your problem. Okay, you need a treatment that works. People think inactivity, behavioral modification is going to fix their back. It's not. It's only going to make it feel better for a little while. But you've got to get it actually fixed. And to fix it, you need the right diagnosis and the right treatment, which is literally virtually impossible in my experience to get out there in the world. Deuk Spine does it every day, and that's one of the reasons we do these broadcasts. We want people to know where to go, okay? If you want to see the Eiffel Tower, you go to Paris. If you want to get your back fixed, you go to Deuk Spine. It's that simple. We're done on this one. This is not go down to CVS and let's do the other. Let's go down to CVS and pick up a pack that, CVS carries at all their CVS's. This is a treatment available only in one place in the world, and it's here in Florida, okay? And you're lucky you found us, but now that you found us, you got to finish. You got to come all the way, get it done. Nobody else offers this treatment, and nobody else is going to be able to do the right treatment for you. Okay? How do I know? I've been doing this for 26 years, and I've seen patients that have been in pain for 40 years plus, and they all say the same thing. They all have the same thing: physical therapy, chiropractic, TENS units and E-stim and biofreeze and acupressure and cupping and everything you can think of. Pain management, stimulators, shots, this, that, and they just keep going back and back and back for more and more and more because they never get fixed. The problem never goes away unless you do the right treatment. For the facet, there's only two things: fusion, Deuk plasma rhizotomy. Done. For sacroiliac joint, Deuk plasma rhizotomy. For the disc, Deuk laser disc repair or fusion. So, yeah. So there is a way to do it. Shot? I thought you were doing a little more for me. I thought you were doing a little more for me, but that's fine. And that is to, you can keep spinning your wheels in the mud the rest of your life like so many people do, or you can get it fixed. Everybody wants an answer. Oh yeah, go down to CVS and get this and take 2 pills and call me in the morning. No, it's a procedure, and the procedure can only be done here. It requires specialized equipment nobody else has. This equipment cost $20 million for the building and all the equipment, and so nobody else has it. That's the problem. And you guys all want the convenience of just going where you live, but where you live doesn't have it. So you settle for whatever they give you, and that is your, pain management shots and rhizotomy, RFAs and epidurals and spinal cord stimulators and fusions and intercept devices and all kinds of crap that doesn't work. Okay? There's lots of doctors out there wanting to treat pain. There's none that can cure it, except for a handful of us. And you're going to have to go to one of our locations to get fixed. Otherwise, you're just going to keep getting treatments that don't work. Okay? All right. Next question.
Next question coming from Lanu, once more on YouTube, asking, is there an age limit for the surgery?
There's no age limit for the surgery at all. As long as the person wants to be fixed and they want to, they want to do something with it, right? You don't just get fixed and then lay around on the couch the rest of your life. So if you want to be active and your pain is keeping you from being active, this is the right treatment. Okay? But there's no age limit. We've fixed 94-year-old people, 94, Okay, a lot of doctors will not touch a patient who's over 80. And there's a reason for that, because the surgeries they have are very invasive and high risk of complication. This surgery is not. You see we lose a few cc's of blood, maybe a nosebleed worth of blood, you got it? But that's it, okay? So there's really no bleeding, there's no scarring, there's no need for pain meds after surgery except for some Tylenol and a muscle relaxer for one night. So there's no risk of, overdosing on narcotics. Like all these other surgeons, their patients have major back surgery. The patients are taking painkillers, narcotic painkillers, muscle relaxers, and they can overdose and die. In my entire career, I had one patient overdose and die. And he overdosed on painkillers after surgery. That was 18 years ago. And, he was a firefighter. And I'll never forget. And it's not anything I did wrong. He took the pain meds more than he was supposed to. Okay? He was prescribed a specific amount, and he just did too many. He was, in pain. And that's the pain he was having. A lot of it was my surgery. It was a fusion. Okay? Not the laser surgery, fusion. And the fusion surgeries are painful. Yeah, our fusion we did this morning has 0 pain. But that's because I've developed techniques over the years to do these invasive surgeries less invasive and safer and less painful and less complications, okay? But this patient that died of overdose, it was a week after surgery, and they weren't blaming me in any way, but I felt responsible in some way because it was my pain medication from the surgery that he died from. I don't know what else he had on board. He may have had some other stuff, okay? But in the end, I was part of that. And so every doctor has patients like that. If you're a doctor, you've ever prescribed narcotic painkillers, you've participated in the demise of patients. The fact is, there's now a way to fix people without the narcotics, okay? But you're watching it right now. And most doctors cannot do this surgery. So they're going to have to send you to us, and if they don't, you got to ask yourself, why aren't they? If this is the best treatment, why are they not sending me to Deuk Spine? And then you'll figure out the answer, which I already know, by the way, and you're not going to be happy with what the answer is. Okay, it's going to be eye-opening. My eyes have been opened over 20 years. Let me have a grabber. It's all about greed. They want to keep the money and the business to themselves. And if they don't offer the best treatment, they're not going to tell you about the best treatment because they want to keep you. They want your money. They want your insurance company's money. So they're not going to send you somewhere else for pain, even if they know about a better option that they don't offer. They won't send you. Now, some doctors will. Those are good doctors, the ones that put their patients' needs ahead of their own. That's the kind of doctor that I grew up with. That's the kind of doctor that I've tried to become. And I feel I've done a pretty good job of it. All right. Next question.
Next question coming from JG on YouTube.
JG, nice to hear from you.
Asking, does the nucleus regenerate the void that was lost?
That's a great question, JG. So the nucleus, which JG is referring to, is the stuff down there, way deep inside the disc. It's kind of in the center. It's a jelly. We call it a jelly, but it's not really a jelly. But everybody calls it a jelly. The nucleus is actually made while you're a fetus. A fetus, for those of you who don't know, is when your mom and dad, at least it used to be mom and dad. Now it could be mom and mom or dad and dad. But your parents got some sperm and eggs together. Sperm fertilized the egg, and then that egg started to grow and divide and make more cells, like multicellular. Multi means many. And in that first trimester, there's this thing that develops from the cells called the notochord, Notochord. Look it up. And the notochord is very important in the developing fetus in terms of instructing germ tissues to develop into the ectoderm, mesoderm, endoderm, which are other types of primary tissues. And they eventually become your skin, guts, muscle, bone, everything. Who you are, right? Part of your body. But then the notochord becomes the intervertebral discs. It becomes the nucleus pulposus of the intervertebral disc. So the notochord, the nucleus is actually an embryological remnant from the first trimester. And you can't make more of it. Once you've made it, it's done. But here's the important thing. You don't need more of it. Everybody is so focused on, let's put back the nucleus. No, you don't need the nucleus. The nucleus is truly just there to keep it from the inflammatory system. It's hidden inside the disc. You don't need it, okay? You need it as much as you need a case of herpes. You don't need it at all. As a matter of fact, the nucleus just sits there waiting to come out and cause problems for you. So you don't want to put back the nucleus. It doesn't do anything else. Now, I was taught, just like you, oh, it's a shock absorber, it's a cushion. And I told patients that for years because that's what I was told to tell them by my teachers. And I believe that, and we all believe it. But the truth is, and I'm the first to say this in the world, the nucleus is actually imprisoned within the annulus inside the center of the disc. It's there for a reason. It's not supposed to be out. It's not, your body doesn't want it, but it has no way of getting rid of it. When you're a fetus, you can't just eject it out into the, amniotic fluid. If you could, you'd do it. So instead, God, in God's infinite wisdom, stuck it inside the middle of a disc and buried it. If you ever watch horror movies, I think there are a couple of good horror movies where the monster, the main antagonist of the movie, is at the beginning of the movie buried in some crypt, right? And then some poor sods come along, usually high school teenagers, and then they somehow release the monster. And then the monster kills everybody, right? That's what the nucleus is. It is that monster. And the annular tear is the way that it gets out. It's the opening of the crypt. So we don't want to put it back because as soon as it comes out, it wreaks havoc. Okay? And creates horrible pain and suffering. All right, we're just about done here. These are pieces of herniation I'm taking out, and so far his surgery is going well. But this is the source of his pain in his lower back, is the annular tear with herniations, causing inflammation. Any other questions?
Yes, this next question coming from Samir on YouTube. Asking, Doc, I had surgery more than 2 months back. My pain is alleviated, but my back feels tender. Can I start a little therapy to strengthen? I am walking regularly.
Well, I assume you're talking about I did your surgery, I believe.
I believe so.
Is that correct? So if I did your surgery, you should already be walking, but exercising. But the therapy, I just would caution my patients on therapy because a lot of these therapists get too aggressive and they may have you do something that could hurt your back, like re-herniate your disc. So I feel the best exercise is walking. And if you're having tenderness, it could be facet joints. It could be piriformis. So there could be another problem. So I would do a telemed. Let's figure out what it is, and let's see if it's something we can fix. But could also be your muscles are just needing more time to recondition. Hopefully that's all it is. All right, you can see the pink material, that's inflammation. So this whole area had inflammation for a long time. Just about done. About 2 minutes left on this disc, and we're going to move on to the piriformis. Yeah, just like this particular patient, he has a piriformis syndrome. Well, Patel's not doing the piri, I am. He's going to do the kypho, but I think I'm doing the piri on him. So I still have to do the piri. What's he doing? What's going on?
I'm just asking because usually the pathologist two machines.
No, that's fine. Yeah, I agree with you. It's called biplanar floral. Biplanar. He sets it up for biplanar floral. Yeah. So Samir, if you're a Samir, I know I would do a telemed so that we can figure out what it is. Okay? And hopefully it is just muscle. And if it is, I would recommend that you avoid therapy and, physical therapist, and just do your own therapy. The walking is the best therapy in the world you can do for yourself. And I always tell everybody for the first 2 weeks, it's 20 minutes twice a day walking. After 2 weeks post-op, then you go to, you can go to a mile. Work your way up to a mile under 15 minutes. We're done. So we're done with that. Everything has gone well. Scope use is a 7. Just irrigating, getting all the fragments out, anything loose. We also put a little antibiotic in to prevent any infections. This time we're done, right? That time we're actually done.
Yes.
All right, bring the fluoro in. We're going to do the piriformis. You can end the live stream, and we're going to go to a piriformis live stream.
Copy that.
So we'll be back in a few minutes.